My name is Joseph Parvizi. I'm professor of neurology at Stanford University Medical Center. I practice as an epileptologist, and I'm the one who came up with the idea of rapid response EEG, as you will see in the next coming slides. I worked with wonderful colleagues and co-founders to bring the device from an idea level to a commercial product level. And it is currently commercialized by a Cerebral company that I helped co-found. In the next coming slides, I'm explaining how the device was designed, how we can best use it. I also want to mention that my contribution to this presentation is not part of my Stanford University duties or responsibilities. I like to mention that the system that we have invented addresses the problem of non-convulsive seizures. Majority of seizures are very difficult to diagnose if you don't have electroencephalography or EEG. Majority of these seizures are so-called subclinical. Number of publications in PubMed throughout the last several years have increased dramatically. Our awareness about this problem is steadily increasing. A lot of patients with various types of neurological problems suffer from this condition. Majority of these seizures, again, are non-convulsive. A large number of studies have been published indicating that non-convulsive seizures cause brain damage. The first one, a classic one that comes to mind, is this study by Meldrum and his colleague that showed that in baboons that were intubated and paralyzed, having non-convulsive seizures, especially prolonged ones, were correlated with significant brain damage in several areas of the brain. Having prolonged seizures correlate with more mortality and morbidity. Percentage of seizure per hour correlates also with cognitive disability at 3 months follow-up visit. A study by Vespa's group at UCLA also showed very nicely that not only seizures, non-convulsive seizures, but also frequent periodic discharges, especially over 2 hertz, correlated with the index of lactate pyruvate ratio, which indicates metabolic crisis. So all of this brings us to the point that time matters. Non-convulsive seizures are harmful and they represent a medical emergency, and we need to identify them and treat them and stop them. Currently, the conventional EEG relies on highly specialized EEG technologists for setup. EEG technicians are precious, they are in shortage, they are overworked, underappreciated, and of course, they are human beings. They have to wake up in the middle of the night, they have to go to the bedside. If they are on site, they probably have other duties to do. They have to monitor EEGs, continuous monitorings. They have to label seizures for the epileptologist to come and review their labeling the next day. So they are very busy, and it takes time for them to get to the bedside and start connecting the patient to conventional EEG system. Devices are bulky, very expensive. A device like this costs tens of thousands of dollars, and you can't put them in your pocket and run to the ED to do an emergency recording. You have to haul them from one place to another. Certainly, you can't do any field recording with those bulky machines. And then you have to wait for the neurologist to get back to your pager and review the EEGs. If we don't have a blood pressure cuff to measure somebody's blood pressure, if we don't have a rapid EEG at the bedside to make the diagnosis of non-convulsive seizures, what do we do as doctors? Well, unfortunately, it's a maze that we have to go through. Many of us treat our patients empirically. Is my patient seizing? What should I do? Do I suspect seizures? Should I treat the patient with anti-seizure medications? Did the medication stop the patient's seizure? Did I treat the patient accurately? Empiric treatment of non-convulsive seizure is a pervasive problem in the culture of neurological practice of today for the following reason. Imagine we have been called to the bedside to make a diagnosis. We go there, we kind of have a suspicion that the patient might be having non-convulsive seizures. More than 50% of the time, we are suspecting that the patient is seizing or maybe seizing, and therefore we tend to empirically treat them with anti-seizure medications. Well, not all of those patients that I treated could be having non-convulsive seizures or non-convulsive status epilepticus. So majority of those, in fact, are not seizing, but I decided to treat them. And minority of patients that I did not treat are in fact seizing, and I decided not to treat because I didn't have high suspicion. So this culture of empiric treatment basically leads to over-treatment or unnecessary treatment of our patients that we have been consulted on, and it also has the risk of missing many seizures and or under-treating those cases where I had suspicion. And this has not only economic and financial problems for the hospital because I overtreated the patient or I unnecessarily admitted the patient to the ICU, but also it has a potential risk for the patient and the patient's brain that I left some of them in non-convulsive status epilepticus for many hours. In those cases where I left them in seizure or I treated them with significant delay, there is evidence that these patients have lower response rate for first-line medications. Usually these first-line medications are a lot cheaper, and if I delayed the diagnosis, basically I make the hospital go with very expensive treatments for these patients, prolonged hospitalization and so on. The cost is a major issue for the healthcare, the suffering of the patient and their families, complication of missing seizures, and complication of unnecessary treatment, intubations, ICU admissions, and so on. Brain injury is a problem that we cannot ignore, especially when it comes to non-convulsive status epilepticus. We need to detect them as early as possible and treat them. Rapid response EEG system consists of two parts. One is the headband system, which is disposable. It can be reused on the same patient, but it shouldn't be used across patients. And the pocket-sized EEG recorder. Both of them have been FDA cleared. Rapid response EEG was not designed to make every one of us to become an EEG tech. This was designed to enable us to make immediate risk stratification. If I give you a device and say that you are going to be able to acquire EEG without knowing how to interpret the EEG, rapidity of acquisition of the EEG is not going to make a major difference. The bottleneck is really from the time of your arrival at the bedside to the time of final diagnosis. And that is made possible through 4 different channels of diagnosis making. So once the EEG starts recording, you will be able to see the tracings at the bedside in real time. The second functionality of the device to enable us make risk stratification is the brain stethoscope function. If you press the button on the right hand side, right by the speaker where there is a logo of a stethoscope, you'll be able to hear the sound of the EEG that's being recorded. This functionality is going to enable us to differentiate the three patterns that I mentioned before. The normal sound is going to be either flat or with very few blips here and there. The second group will be the ones who have rhythmicity and periodicity in their EEG, maybe more sharply contoured waveforms. These discharges are separated from each other in time. When seizure is being recorded, the sound is very unpleasant and continuous, repetitive, and loud. Third functionality of the device allowing risk stratification is Clarity AI algorithm. If you press on the seizure burden button, you'll be asking the computer to quantify the amount of seizure or seizure-like activity in the last 5 minutes and plot it in a line graph for you and give you a percentile measure. This is not the probability measure, but the percentage of time in the last 5 minutes where epileptic activity was abundant. Once you click the button, the 5 minutes of EEG will be divided into 10 seconds long bins of EEG, and the machine has been taught to identify patterns that are compatible with epileptiform activity. It will identify this for every single channel, every single electrode, and will quantify how much of the pattern exists in the last 5 minutes, and it will give a value. After 10 seconds, it will do it for the next 5 minutes. So it's a rolling window. Every 10 seconds, it's moving forward, and it's giving you value after value. If these values are plotted as a line graph, you will see the values going up or down. We have also identified thresholds of 10, 50, and 90% to identify frequent, abundant, or continuous seizure activity. And these are consistent with the recommendations made by American Clinical Neurophysiology Society. If the line crosses the 90 percentile level, it means 90% of the last 5 minutes was spent in seizure-like activity. And that is how the device starts acting. So the algorithm will be plotting the line graph on the device, and you'll be able to see how the seizure burden graph has been trending up or down. On the device, you see there's a number as a percentage given, and that percentage is the seizure load in the last 5 minutes. 96% as shown on the screen means that 96% of the last 5 minutes recognized as possible seizure activity. And that means basically more than 4.5 minutes of the epoch was in seizure. So the patient might be going into status or might be in status epilepticus. And when that happens, the device plays an auditory alarm to make sure that the nurse comes to the bedside, and by that time the device has also turned the screen into red, continuous seizures detected. This message doesn't necessarily mean that the patient has been diagnosed with status epilepticus. It is a suggestion that needs to be verified with a thorough review of the EEG by an expert. I like to emphasize that the algorithm was designed to be more sensitive than specific. So as you see in the lower left corner, the potential for brain damage is extremely low if a patient is suppressed, for example, burst suppression, or is having normal or just diffuse slowing. As the patient starts going towards non-convulsive status epilepticus, the metabolic rate goes up and the potential for brain damage goes up. And of course, the worst case scenario is that somebody is in convulsive status epilepticus, as shown in the top right corner. What I like the viewers recognize is that there is always a gray zone. It's never a clear-cut distinction that this is
normal, this is abnormal. The clarity algorithm, the artificial intelligence, as its crudest form that is currently commercialized, is designed to identify anything to the top right of that curved line. It's going to be identifying many patterns of periodic discharges as well as non-convulsive status cases and will alert the user to take a second look.
A question that comes to everybody's mind when we talk about AI performance is how it compares to humans. In a validation study, we selected randomly 353 EEGs, cerebral EEGs, that were collected from 6 hospitals, academic and non-academic small community hospitals. We gave it to several EEG specialist neurologists with EEG training to read these EEGs and label them as non-convulsive status epilepticus, meaning more than 5 minutes of seizure activity in any given channels, seizure activity less than 5 minutes, highly epileptiform patterns such as frequent, periodic, and or rhythmic epileptiform discharges, and the rest, which is basically anything that's non-epileptiform, rhythmic delta activity, slowing, or normal. Of 353 EEGs, this is what we got when humans labeled it versus the machine labeled it. All the 9 status epilepticus cases were labeled correctly by the machine. 3 of 33 alarms were so-called false. 21 of them were too sensitive, but still pathological. One might argue that the epileptologist needs to take a look at these EEGs anyway. But I personally am excited about this number, 157. This is why I'm excited about the AI. Imagine you are in a hospital that you have to get 353 pages during after hours, weekends, or any time because the EEG was done and you need to read it. If you don't have AI to help you, all 353 times you have to wake up and read the EEG right there. But when you have an AI, and let's imagine that all 353 EEGs were done during after hours, after midnight. So what happens is the following. Of those 353, 179 of them, you won't get a page. Of those 179, only 2 had seizures, but none of them had prolonged seizures. So 20 of them were highly epileptiform patterns, but for the most part, they were all normal or diffusely slow. I'm also very excited about the AI because in those 9 cases where the patient was in frank status epilepticus, non-convulsive type, the ED physician who did this study, who set up the EEG after 2 a.m., didn't have to wait for the neurologist to detect these cases. And of those so-called false alarms, for the most part, they were highly pathological to begin with. Now the question is how to integrate this AI algorithm into our workflows. Here's a workflow that I want to run by you. We have to understand that the AI output needs to be interpreted in the context of the user's own pre-test clinical suspicion. For example, if you are a clinician and you have a very high suspicion that this patient is having seizures right now, if the clarity says over 90%, then definitely treat as soon as possible with a load of anti-seizure medication. If the suspicion is very high, but the AI output is somehow dubious, it's definitely not over 90%, that's when we can actually just wait, not treat, until we have confirmed the pathology by expert. If the expert is not available, then we just go with our clinical suspicion and treat them as we would have done if we didn't have the AI. If the suspicion is very high and the AI output is definitely less than 10%, then we should definitely wait and not treat the patient until we have the EEG pathology confirmed. This is a place where we can save the hospital from unnecessary treatments, from unnecessary ICU admissions, and so on. And again, if the suspicion is very low, we guide our treatment based on AI output.
For example, if the suspicion is low and the AI output is less than 10%, in those cases, definitely don't treat. Wait for non urgent review of EEG next day. So, overall, yes, there will be many overcalls, but intentionally, this algorithm has been designed to be more sensitive than specific because we want to capture these nine by all means. But at the same time, we want to also rule out these cases where a neurologist doesn't need to wake up in the middle of the night to review the EEGs. And then lastly, the remote visual review that's made possible through cloud connection. If you go to the portal, you'll be able to see the output of the Clarity algorithm. As you see here, patient has been in non-convulsive seizure on the left side, and here you see the seizure burden increasing. Again, the vertical line indicates the seizure burden at that moment for the last 5 minutes. Here's another case. At this point, the seizure burden is reaching the 90 percentile, and at the bedside, an alarm has been triggered. In the slides ahead, I'm going to explain how this device can be best used for immediate risk stratification using the EEG display on the device, the sonification module, EEG portal, as well as on-device artificial intelligence algorithm that is currently commercialized and being used. Back to the maze and back to the clinician facing the dilemma of treat or no treat. The rapid response EEG is meant to help the clinicians in that emergent setting by stratifying the risk and by triaging the patient into three following groups. One, patient has normal or slow EEG, status is ruled out, do not overtreat, do not overkill, wait, and reassess. Two, patients with highly epileptiform patterns that indicate the patient might be at risk for seizures, might benefit from prophylactic medications, and certainly in these cases, long term monitoring is indicated. And third, those cases that are having frank seizures. And then the third, those cases of non-convulsive seizures and or status epilepticus that need to be treated immediately. And we need to watch the EEG to see if we have stopped their seizures effectively, whether or not we have given the right medications. And in these cases, of course, case by case, we can determine whether or not they need long term monitoring. If a patient in the emergency department is detected to be in partial non-convulsive status, we have loaded them with anti-seizure medications. They have returned back to normal. They are waking up. They are walking and talking. No need for long-term monitoring, of course. No need for admission. If it's normal or slow, don't overkill. If it's highly epileptiform pattern, definitely think about long-term monitoring and maybe prophylactic medications. And if somebody is in status epilepticus, don't waste time. Start acting. For those of you interested in knowing whether or not 10 electrode system will have the same sensitivity and specificity as 16 plus full montage EEG system, refer to the references that are listed here. In the next few minutes, I'm going to cover cases that are going to benefit from rapid assessment. Those are patients who are altered and are either COVID 19 positive, or they suffer from contagious infections, or they are under investigation for such infection. We don't want to expose our EEG technologists or our conventional EEG machines to infection in these cases. And also in those cases when EEG has been ordered, but our EEG technologists are unavailable at that moment. We don't want to wait until they become available.
cerebral EEG can be used in these cases immediately. Patients who have altered mental status without any explanation, or those with recent clinical seizure, prolonged convulsive seizures that are now not returning back to baseline. Are they altered because they are postictal, or are they altered because they have received benzodiazepines en route, etc.? And patients with altered mental status that have a condition that we have already diagnosed, such as stroke, trauma, CNS infection, tumor, anoxic injury, including cardiac arrest, but their level of altered mental status is not commensurate with the known CNS problem. Lastly, those cases with episodic or repetitive movements that need to be diagnosed as whether or not they are seizures, or in some special cases, whether or not those episodes are non-epileptic.
If somebody is having normal EEG, you will see it like this. You have a nice posterior dominant rhythm, or the alpha rhythm, in 8 to 12 hertz range in channels 4, 5, and 9, 10. Slowing is seen like this. Burst suppression will be seen like this. And if you sonify this, you will hear something like this. Lateralized periodic discharges, generalized periodic discharges, seizures, focal on the left side, another focal seizure on the left side, and then non-convulsive status epilepticus.
Is the case of a 33-year-old man who has a confirmed diagnosis of idiopathic primary generalized epilepsy, who had been drinking quite heavily prior to his arrival to the emergency department. The ED doctor became concerned about this case and consulted the neurology service. Neurology suggested cerebral EEG right away. The ED doctor put the cerebral headband on the patient, connected it to the recorder, and listened to the sound. As you see, loud, repetitive, continuous, not flat tone. That's why this is very concerning for seizure. He called the neurologist right away, and the neurologist went to the portal and reviewed the EEG waveforms. This patient was treated in the emergency department right away with a load of valproic acid, and shortly thereafter, patient regained his awareness, stopped confabulating, and his altered mental status improved rapidly. Afterwards, the patient was discharged from the emergency department. He confessed that he has not been taking his anti-seizure medications in the last week. The second case is the case of a highly functioning individual who came to a major academic center after witnessed convulsive seizure at home. This is a patient who has a known tumor in his right temporal lobe. After convulsive seizure, he was not returning back to baseline. The emergency department was very concerned about the case because he was severely altered. They didn't know if the patient is suffering from postictal state or the patient has received benzodiazepines and that is why he is After consultation with the neuro-ICU team, they decided to admit him to ICU. The fellow in this large academic center grabbed the cerebral recorder, put it in his pocket, and ran to the emergency department and applied the EEG at the bedside. He ordered fosphenytoin stat as this patient was having partial status epilepticus in the right side. 19 minutes after the fellow's arrival at the bedside, seizure was stopped. For a long time, physicians taking care of their patients in the front line within hospitals, they have always faced a dilemma when they were suspecting non-convulsive seizures. Is this patient altered because he or she is having non-convulsive seizures? Is this patient in status epilepticus? What should I do? Should I treat the patient? Did I treat the patient right? Did I choose the right medication, the right dose? I'm hoping that the device that we have invented will empower our clinicians to make the precise diagnosis and also choose the right treatment option, to practice precise medicine and to help our patients and not let any patient linger in status epilepticus for too long. Time is brain, and this also applies for seizures and non-convulsive status epilepticus. The more time that passes without precise and effective diagnosis and treatment, the more brain damage the patient will suffer. So let us help our patients and let us empower ourselves to practice precise medicine. Thank you so much for your attention.